The proceeding will start shortly.
2, 1. Order. Welcome to the Public Accounts Committee on Wednesday, the 13th of March 2024. Today we're looking at the Department for Health and Social Care's annual report and accounts, which sounds dry but actually, of course, lays out all of the expenditure on health across the last year, well, the year to ending 23. And in 2023, we reported then that the department had overpaid and over-ordered £14.9 billion of inventory with vast unusable quantities of PPE in storage. And that was a significant cost to the taxpayer. And we also looked at issues around the UK Health Security Agency, which of course had been established midway through a financial year. And that's why Professor Dame Jenny Harries is with us again today. This year, the accounts are late still, partly as a result of the COVID challenges, and we do recognise that. But the Controller and Auditor General has been unable to provide an opinion on the accounts of the UK Health Security Agency and has identified concerns elsewhere in the DHSC accounts. So we know these are matters that you take seriously, we do too, so we want to get to the bottom of why that is and when things will get regular again, because we want to have the positive confidence that they will. And we know it's not a willful process of yours, but there are concerns we need to raise today. So we want to really hear from you about how you will address these. And of course, there are other issues in the accounts that we will touch on as well. But before we go into the main session, I will introduce our witnesses and then I've got some other questions. So we have Sir Chris Wormald, of course, who's the Permanent Secretary at the Department of Health and Social Care, joined by Shona Dunn, who's the Second Permanent Secretary at the Department, and Andy Brittain, who's the Director General for Finance at the Department, but also oversees the finance side of the UK Health Security Agency, though he's not the Chief Finance Officer for the agency, but he has a line management responsibility there directly. And Professor Dame Jenny Harries is the Chief Executive of the UK Health Security Agency, which, to remind people, was established in September of 2021. So midway through a financial year, which is one of the concerns we've had about how some of the challenges it's faced have come to rise. And we have Julian Kelly representing NHS England, where he's Deputy Chief Executive and Chief Financial Officer. Every time someone appears in front of us, they've got a longer title, so I'm not sure if that's efficiency savings or productivity in the NHS, but we'll live in hopes. But I wanted to raise, so probably starting with Sir Chris, back in 2018, this committee produced a report on continuing healthcare and the funding of that. And we, at the time when now Lord Stevens was in charge of NHS England, so Julian Kelly will no doubt want to come in on this as well. And we were very concerned then about how the efficiency savings that were being earmarked for that were going to actually bite. Since then, the BBC has done some research about the eligibility for receiving continuing healthcare, and it came up with in its research with some quite disturbing figures, including the regional variation on eligibility, which range from 50% of adults who apply getting support in some parts of England, of course this is England we're looking at here, to less than 10% in other areas. And for under 18s, eligibility rates ranging from 14% to 96%. In the year 22-23. There also, I won't go through the detail. It was a journalistic bit of work, so it's all on available. But some families being denied funding after a medical assessment, and then another panel without talking to them, refusing support. Now we know this is an expensive area for the department and the NHS, but these are very worrying figures coming out of the BBC. So I really wanted to hear from you, Sir Chris, what the plan is for managing continuing healthcare so that the patients who need it are getting the support that they need and deserve.
Yeah, well, as you say, this is a shared responsibility between the Department and NHS England, so I'll hand over to Julian Kelly in a bit on the sort of operational bit. Essentially, the Department does the policy and the legal framework, and then NHS England does the operations. Now, obviously, it's an incredibly complicated area. I mean, I think when we did this in 2018, we had nearly 3 hours just on this subject. So obviously we can only sort of touch the sides today. As you say, it is both an extremely expensive and growing area of the budget and extremely important to the individuals concerned. In terms of the policy, the absolute heart of it is individual decision-making about the individual in front. We do not have quotas, we do not have regional targets, and given the different demographies of different places, we would expect quite a divergence of what happens in individual places. Now, whether or not that justifies the numbers you read out, we'll need to look in to further. But this is not, categorically not, a thing you just roll out equally across the country. As I say, the absolute heart of it has to be individual decision-making based on a clinical diagnosis of the individual. We set out extensive policy guidance about how those individual decisions should be taken, and then NHS England operationalises those decisions. So to get to was an individual treated fairly or unfairly, you'd really have to look at the individual cases, which of course we're happy to do offline, but now is probably not the time. And then NHS England takes an oversight of how does it work out in different places, at which point I'll hand over to Mr. Kelly.
So I don't know which aspect you'd like me to start with, but on eligibility and variation in rates, we do track that. In particular for the adults, I can come to the children briefly in a minute. There is variation, as Chris has said. I mean, a major reason for that is sort of different demographic profiles, actually to some degree different services that are offered elsewhere in the community that would otherwise provide some of this care, including between the NHS and local authorities. We track by classifying ICBs into 7 categories depending on their demographic profile. When you do
ICBs,
that,
integrated care boards.
Sorry, my apologies. Integrated care boards who are responsible for commissioning the services and making the decisions. When you do that, actually the variation shrinks. I.e., there is variation due to those.
You benchmark peers against.
So we do benchmark peers. We do spot where the outliers are. We have gone in previously and audited some of the individual decision making where we have outliers, at least to confirm that the decision making is robust. Where it isn't, we agree improvement plans. Since 2018...
Just to be clear, with outliers, those who are granting more and less? Or
yes, both. Because, as you may be granting too much or too few. There has been both a narrowing in the kind of level of variation since 2018 between the commissioners. I mean, the commissioning body has changed in that time, but there has been a narrowing in the variation of application rates, which would at least indicate that there is kind of better understanding in populations what is available. And we have seen a narrowing, by less in the variation in what we call the conversion rate, i.e. what percentage of applications are accepted. And we continue to work with the outliers, and we continue to look at how we can improve the way we audit where that is appropriate, the decision making. Do
you have enough money for it? Because we looked at it and you were going to be making 855 million in efficiencies, which we were worried was going to be causing problems, and now we're seeing challenges.
Since I think it is about 2018, actually the amount we spend on on all age continuing care has gone up by about 50%. So it is a major cost pressure. That is a combination of actually the implications of the fair cost of care policy adopted in social care, as that flows through into NHS continuing health care, the national living wage. We have definitely seen an increase in the complexity of the cases that we are funding. We particularly see that in the children's side. I think you're seeing very similar issues in local authority children's social services. So we certainly haven't reduced the amount we are spending in this area. In fact, it has increased substantially. It is a significant cost pressure.
Okay, well, we put...
we could write to you with an update on that bit. So I'm stretching my memory for 6 years, but I think the savings we talked about were against the counterfactual of where the budget was expected to go. They weren't about the cash sums in that area.
And as Mr. Kelly says, the numbers were going up, so we were concerned about that juxtaposition. If you could write to us an update, and then we may then pick it up in a future session more specifically, because it is hugely important for those who receive it. and very challenging if it's reduced when they're expecting it. And there's not many options available unless you've got lots of your own private money, which obviously is not the case for most people. And indeed, it's an NHS service, so it should be provided. So we'll continue to watch this, and we're not we're aware of the pressures, but that doesn't mean it should not be being provided to people who need it. Thank you very much indeed. So, Sir Geoffrey Clifton-Brown, Deputy Chair.
Thank you, Chair. Good afternoon to all our witnesses. Could I come to you, Mr. Brittain, please, and refer to the Health Service Journal issue of the 27th of February, where they report, and I'm asking whether this is correct or not, that you have taken £1 billion out of the capital budget to fund the ongoing industrial action. Is that true? Because I've got then follow-up questions.
So the industrial action would be for the current financial year rather than the year that this that is referred to in this accounts. I would need to check that precise figure, but I mean there's a general principle here, which is that when unexpected costs emerge across the department and in the NHS, we of course look in our own budgets first to see to what extent we can reprioritise. And then we enter into discussions with the Treasury, where we also look across resource and capital budgets, where we forecast underspends in capital budgets because delivery is going more slowly than expected, and therefore there is some headroom. Then we do use that. So absolutely, we're not consciously slowing down programmes or delivery. It's where delivery is slower than expected and money is available. We use that. On an exceptional non-recurring basis. So when we had the industrial action discussions this year, we did go through that reprioritisation process, and we did reprioritise an element of capital. I need to double check the precise number you quote.
So it's true. Given that the hospital building programme is under such pressure, particularly with things like RUC, this is surely a very unwelcome development, because £1 billion would build you a new hospital or thereabouts. And it's something this committee has railed against before, raiding the capital budget to pay current expenditure. So how do you justify that?
I don't characterise it as raising the capital budget. As I said, it's where delivery is slower than expected against plans. And therefore there needs to be a reprofiling against delivery and the budget associated with that, and therefore underspends emerge which aren't going to be used for other purposes. Then we put them towards emerging pressures such as that.
I feel a gloss, Mr. Brittain. Presumably you have a capital budget for a reason.
Yes.
And presumably you plan to spend it.
We plan to spend it when it is set.
Particularly when there's such pressure
Yes.
on the hospital building programme,
Yes.
accentuated by RAC. So what is the effect on the hospital building programme? What effect is this going to have on the hospital building programme?
So, I mean, I think the committee's recently discussed the hospital's building programme, so I think the detail of that is well known. I think compared to when the profile was set in the spending review, the delivery has needed to be reprofiled against that, and that is where these underspends are emerging. We are working with the Treasury to reprofile the overall costs of the hospital building programme so that we can work towards the aim of eradicating RAC by 2030, which is when the hospitals need replacing by. So the overall aim remains intact. It's the profile that has changed.
Well, thank you. We'll keep an eye on. We constantly keep an eye on this issue. Sarah Owen MP.
Thank you, Chair, and hello to all our witnesses. I wanted to ask two questions specifically about changes of guidance and the ability to fund those changes of guidance and the support given to trusts. They're both close to my heart. The first one is around the NHS's announcement today that guidance will change to give 2 weeks bereavement leave for people who suffer miscarriages, which is incredibly welcome as one of many campaigners for miscarriage bereavement leave and somebody who's suffered multiple miscarriages myself. I can't tell you how welcome this announcement is and how important it is that it's the NHS that have done this as one of the largest employers, but particularly of a women workforce. And it proving that it's necessary but also possible, and it is that possible part that I really want to push on now. How is NHS England ensuring that trusts can actually do this and to fund this and are supported in this changing guidance?
So, when we decided to do this in response to the recommendation from the government's loss of pregnancy review, we looked at the cost. I mean, in the grand scheme of the kind of total funding to hospitals, when you calculate it, I forget the precise sum, and if you want to know, I can go and find out. But it is a de minimis amount of money, and in some cases, trusts were already doing this. So it is actually saying, no, we are, insisting that everyone just follow the standard. And as I said, in the grand scheme, the numbers, it's always a tragic situation, but the numbers are quite small, and our estimate of the cost is sort of reasonably de minimis and therefore sort of manageable within the kind of total funding envelope.
Fantastic. Would you be able to share those costs with me? Because I think it would help show that the NHS is leading the issue on this for other employers as well that might be reluctant or worried about how it would impact them. The second one is, having been a HCA, I know that the guidance changed in 2021 around the agenda for change from band 2s to band 3s and that uplift. What's the department done to ensure that trusts have the resources and funds to support this uplift and also the associated back pay as well? Who's best to answer that? Is that Mr. Brittain?
I'm happy to start. So the position didn't actually change in 2021. What was done was the actual rules were clarified so that the terms on which we should have been evaluating job roles, we clarified what should have been happening. Now, at that point, this does cause a cost pressure because clearly now trusts have had to look at where they have banded people at 2 rather than 3 and where they're doing a job which should be at 3, and those discussions between unions and individual trusts are ongoing, and we and trusts are having to manage that cost, both the kind of non-recurrent element and the recurrent impact on an ongoing basis. That is one of the financial challenges that we are, and have been grappling with.
And just to be very clear on this, is there additional funding being made available to the trusts that are really struggling with this? And if not, why not?
There hasn't been specific additional funding, and in part because they as employers are responsible for the way they employ their staff, i.e. this was a clarification of what should have been happening, and we haven't therefore taken money off other people in order to fund specific trusts who have had to sort of adjust what they are doing with staff. Nonetheless, it does create a pressure, and as we are discussing with individual hospital providers and the systems of which they are a part, we are having to discuss what that means for both what they can deliver and the funding they need on any given year. And in part, the rate at which trusts are sorting this out is also differential, so it's not as if there has been like a single rule as to what individual trusts have to do, because they all find themselves in different situations. It really is like an employer by employer with their staff issue.
May I allow?
Very well.
Thank you. And isn't there a sense of duty and responsibility from NHS as an overall to some of the lowest paid members of staff that have been for a number of years now in different areas and different trusts doing more than what they've actually been paid for? Isn't there a sense of responsibility and duty? Albeit that you've said that the individual trusts are the employers, actually isn't there a responsibility here from the NHS?
It is the responsibility of the employer to sort those issues out with their staff. They are supported by NHS employers. Indeed, I've been in some conversations with trusts only in the last few days on this very subject.
I think what Ms Owen's driving at is if you're a healthcare assistant and that's your title, that your job is a certain job, and that's something that the NHS overall would agree.
Yes, and the guidance, as you say, was clarified in 2021 for exactly this reason, and it's the job of the employer to make sure they're employing people on the right basis.
But if the guidance wasn't clear in the first place, surely there was a responsibility there on yourselves for having unclear guidance for a number of years and allowing this ambiguity to take place.
Well, as I said, I don't commission NHS employers, but they clarified the guidance in 2021, which I think was just to be absolutely clear to employers, that no one could hide behind.
Okay, thank you very much for that. We do need now move on to our main session, which is to look at least a portion of the Department of NHS and Social Care's annual report and accounts. So it's a large document. We won't just make it clear we're not going to cover every inch of it. I'm sure witnesses will be relieved to hear, because we'll be here forever. So we're trying to pick out the edited highlights, I suppose is a simple paraphrase. And to aid us and kick us off on that footing, Sir Geoffrey Clifton-Brown, the Deputy Chair, is going to lead off.
I think these are questions probably for either you, Sir Chris, or maybe Andy Brittain. I take you to the sort of middle of the report, page 223, and it says under the heading of Management of Personal Protective Equipment Inventory, as part of its response to the COVID-19 pandemic, the department procured 13.6 billion of personal protective equipment, and it then has written down an inventory in these accounts of staggering £9.9 billion you've written off. So a few questions around that, if I may, please. In deciding to dispose of these huge inventories, what consideration was given to actually giving some of this equipment to other needy people, like in the third world? For example, I'm sure some of the people in Gaza could well have used some of these stocks.
Well, we have a hierarchy. I'll ask Andy to go through the detail, but just as a matter of fact, of course, the 9.9 billion referred to here is the write-down since 2021. And indeed, I think the amount of the write-down in this year's annual reports is
240 million.
Is very, very low indeed. We've, of course, debated that write-down at length with this committee. As you know, a large amount of it is simply the change in the asset price from what we bought at a very high level in the middle of the pandemic, and you all know why.
Oh, well rehearsed.
And
we know all that.
Yes. No, I'm merely clarifying your initial statements, Geoffrey. On the specifics...
Very specific. What consideration have you given to giving this equipment away, particularly to the needy people, maybe in the third?
I mean, thank you. We have, of course, with the stockpile, we keep it under regular review, what we're doing with it, and we manage it in accordance with the government's higher waste recycling hierarchy, which looks first at reusing it, so that is sales or donation. Well, at first it's using it in the NHS and health and social care settings. Then the next step down is looking at sales and donations, and we've had an extensive international engagement programme to see to what extent other countries would like to use and take hold of our PPE. And then the next step down is recovery, which is energy from waste, and the final one, which we seek to avoid, is landfill. So, I mean, we continually review the stockpile through the lens of this hierarchy. So, to the extent that countries are willing to take it, that has been looked at.
Well, I hear that answer, Mr. Brittain, but if you go over the page, 224, on paragraph 5, it says in 22-23, the department did not perform a full and complete stock count on its PPE inventory, including that held in containers. The department has said that a full stock count would cost 70 million. But 70 million, in terms of the amount you've written off, 9.9 billion over the last couple of years, is small beer. And if you don't know what you don't do that stock take, how do you know what is usable and what is not usable, what could be given away and what could be sold?
So we absolutely know what inventory, we know what PPE inventory we have and where it is. The subtlety here is that we were unable to give the NAO access to we were unable to gain access to it ourselves, and for the NAO to do an audit to actually physically count it, because it was in containers stacked up. So that's why we were unable to do that. The 70 million, we took the view, because we were going through the we were working our way to reducing the stockpile. We took the view that spending £70 million to count all this would not be value for money, and in fact it would have delayed the plans to dispose of the stockpile by quite a significant extent, and that in fact we've managed to accelerate it and save a further £130 million against our costs. So for that reason, we took the view that it wasn't worth counting the inventory in sufficient detail to provide it up to audit evidence quality.
Well, I hear that answer too, but given that we're a large number of unopened pallets, I simply don't know how you can know whether they were either fit for use or whether they were fit for resale or not. But let's move on. You've an answer to that question. Let's move on now to the future, and that's just the strategic reserve. I am concerned that you've disposed of this large amount of equipment, and it's going to take at least a year for the COVID inquiry, to establish what the causes and what the preparedness for the last pandemic was, and given the likelihood we're likely to get another pandemic, how are you considering getting rid of all this stuff compared to keeping it as a strategic reserve in case you need it for the next pandemic?
So I mean, the stockpile we have at the moment is not of the right sort. So it's expiring. Some of it is some of it's not fit for use in health and social care settings. So we are getting rid of what we do not need. Separately, we are working to identify what a sufficient pandemic stockpile would be.
You got rid of it all before you're working through what it should be.
No, sorry. Mr. Britton's point is the stuff that's being disposed of is the stuff that we can never need.
Yes.
Because normally because it's going out of date, as
yeah.
it were. So it wouldn't. There were no circumstances in which it could be used for a long-term stockpile. I think
exactly.
Thank you.
Okay.
I sort of interrupted you mid-flow.
No. So, I mean, for future stockpiles, we will base the size of the stockpile on the reasonable worst-case scenario for pandemic and emerging disease risks, and that works in hand now to work out what that is and make sure we have the stockpile of sufficient size for that.
So, on the recommendation of the Treasurer Minute, you committed to doing a regular update to Parliament. When will you be making the next update to Parliament?
Or an update to Parliament on what, sorry?
On the whole of the...
On the PPE.
On this whole PPE.
So the last update we provided to you was in November 23, and I think that's the last one we committed to provide. We're currently thinking about what future updates we should give. I think whether that's annual or not, but we're just thinking
Perhaps
about
we can discuss that offline.
Of course.
We want to make sure it's useful information in real time, but on the other hand, if 6 months it becomes too frequent,
very happy to do that.
We can negotiate, but we help on that one. So
I think final question from me on this area, one of the two of you. Back to what I was talking about, this strategic reserve. You said you were working through what you need for a future pandemic. When will those deliberations be complete?
And I think we shall await. Well, we as I said, we are deciding what stockpiles we need in light of the reasonable worst case scenario for pandemic and emerging risks. I think we will also take note of what the COVID inquiry decides, and we will update our plans in response to that.
Yes, and just I think you said a year on previous. I don't think that is the inquiry's plan. I think their plan for Module 1, which is the pandemic prep bit, is to report as soon as they can, because as I expect you know, they're trying to do it module by module rather than a grand report right at the end. Now, of course, we're still in the wind-down period of the stockpile, so we're pretty confident we've still got more PPE than we would ever want to retain for a future pandemic. As we come out of that wind down, you're correct, we will have to take decisions about exactly what we want to keep long term, and as Andy says, we'll want to take account of what the inquiry says in taking that decision.
Thank you very much, Sir Geoffrey. Sarah Owen MP.
Thank you, Chair. Just to follow on from Sir Geoffrey's points, the COVID-19 procurement wasn't just about PPE, it was also about other pieces of equipment. So I want to focus on ventilators. £569 million spent on ventilators, 20,900 individual ventilators at the time. Can you explain why such large volumes of ventilators have been scrapped rather than actually being donated or sold, as Sir Geoffrey had said, perhaps to developing nations that might need them or best use them, or why they weren't sold in the first place? I think that's probably to Mr. Brittain.
Yeah, of course. So, yes, we did have a COVID ICU reserve, which includes the ventilators you've just described. That was a strategic decision was taken to close that in February 24, so we're now working through how we will dispose of those precisely. That's being worked through in a slightly different hierarchy, which is the value retention activity model, as it's called. So this looks first to try and donate ventilators into the NHS. Then if that's not possible, it looks to return them to suppliers for buyback. Then if that's not possible, we look to international humanitarian donation. So again, we will check with which other nations want these. Then if that's not possible, we look to auction on the open market. Then finally, we look to disassemble and recycle them. We have a zero zero waste to landfill policy for this particular item of equipment. So we do go through that hierarchy to make sure we get the absolute best value for money out of the equipment that's available.
Yeah, the only thing I'd add, and I expect you know this from your professional background, but ventilators are much more difficult to donate into the third world because they are reliant on having quite sophisticated hospital oxygen systems to make them work. Indeed, the limiting factor to how many ventilators you can run is very frequently the pipework of the hospital, not how many individual ventilators you've got, and therefore they can normally only be used by people who already have sophisticated hospital positions, which doesn't mean we don't try, but it's more difficult than with some other medical equipment to find people who can actually use them.
Completely understand that. I'd just like a follow-up question on some of those options that you've said that you're going to work through. Have you made an estimate of how much of that money, of that £569 million that you will get back? And what the likelihood is that ventilators could be used elsewhere, and what you would get in return for the buyback scheme from manufacturers?
We haven't yet because it's a work in progress effectively, so it's a dynamic position at the moment. The work is actually only really just happening at the moment, so I haven't got an estimate available at the moment. When do you think that work will be completed? It'll be ongoing until we have worked through the amount of equipment we have. I'm very happy to give you an update on the position as it is at the moment, if that would help.
And has this meant that there's a pause on the NHS buying ventilators, given that you have 20,000
I'll have
available?
To ask Mr. Kelly to answer that one. I'm not cited on that. I'm not sure if Mr. Kelly is either.
I'm not cited on the specifics, but I mean it's as with PPE actually that we have used the kind of first port of call for the stocks that we already have.
It'd be really useful
I
to
don't know like specifically whether anyone has gone and bought.
It just would seem a little bit ludicrous.
Yeah, I think it's quite. We'll go and check. I suspect you're right. I think the only caveat would be where people are buying very specialist equipment that we don't have in store. We'll go and check the exact position for it. But as we're making it available to the NHS first, it would be slightly surprising if anyone was buying new ones.
Surprising but not impossible.
As I say, there may be very specific reasons why a particular type of ventilator is needed in a particular type of environment. We'll go and check.
I think I would say, because not every member of the committee was on the committee when we looked at the ventilators, and not everyone will pick, but when we looked at this issue, we recognised that it was an expensive programme to deliver, and in the end it was because at the time, of course, everyone thought we needed ventilators, so it was not entirely a surprise that we've got a lot of ventilators that we didn't need. So it was a right decision to do it, even though it was costly. But we now have this problem, as Mozoin is trying to sort of wrench money out of value for money out of this decision, even at this late stage.
No, it's important that even if it was the right thing to do at the time, we get best value for the stocks that we have. So I don't think there's any difference between us and the committee on the objective here.
Absolutely, and that leads on really nicely to my next question around the Nightingale hospitals. Absolutely the right thing to do at the time, but obviously trying to get best value for money post that is really important. How is recovering costs for the Nightingale hospitals, which actually weren't really needed to the extent that they were expected to, going? I think that's probably best to you, Mr. Brittain.
So, the 7 Nightingales were set up to provide surge capacity at the start of the pandemic. All were decommissioned in 2021. So of those 7, there's no impact on this year's accounts, and all of the costs of that have been already incorporated in previous sets of accounts. There were separate surge hubs set up during Omicron, but I'm looking to Mr. Kelly again. I believe they've been closed down now as well.
Yeah.
And how has it... I was asking specifically about progress in terms of how you have done in recouping some of those costs, because the NHS lost £13 million in just beds alone, in unused beds, and it's been reported that they're being sold for as little as £6 when it cost £2,500 in the first place. Surely we could have found better use for those beds or got more money for those beds, which many of them were unused.
The same principles will apply as to ventilators, where we will look to, where there was spare equipment from the Nightingale hospitals, we will have first, of course, looked to provide it to other NHS trusts. If they did not want it, then we would work down the hierarchy to get the best value for money out of it. I mean, I can't comment on the specific figures you've just quoted, but that's the general approach we would have taken.
And would you have looked just to keep in the NHS, or would you have looked at the care system as well and to share that resource?
And again, the principle is that we would look across the health and social care system. We'd have definitely done that with PPE, for example. So we would look across the system.
And you say this work is ongoing. How is it that...
Not for Nightingale.
Not for Nightingale.
No.
Okay, so how is it that there have been reports that beds have been sold for £6?
I mean, that may be possible. As I said,
oh.
Well, because if the decision is taken to sell equipment on the open market, it will sell at the market price. I can't comment on the specific figures, as I say.
Despite them being bought for £2,500?
So again, I'm not able to comment on the specific figures you're quoting, but in principle, items of equipment, if they are not required for the NHS or other settings...
Are you doing anything to make sure that you're not flooding the market? Because if there's a lot of hospital beds all for sale at the same time, maybe they do go cheap.
I mean, again, we will go away and check this, but since they were closed in 2021, I really don't believe that there is any equipment from Nightingale's which is still left to be disposed of, but I will go away and check that.
Yeah, and also just check, I mean, and then presumably there was a plan to sort of sell it into the market at a reasonable pace.
Yes, of course, yeah.
Good, just being reassured on that. Thank you. Ms. Owen.
It's done.
Well, no, I was going to say, I believe all of this stock was disposed of by July 23, and it was disposed of through auction, through donation, and through disposal. So the specifics you mentioned, of course, without knowing the precise bit of equipment and the condition it was in, and its uses and so on. Of course, that is perfectly possible, but unlikely, and I'm sure would have only occurred in a few circumstances. Through those different routes, we definitely will have generated the best value we could. What we were, of course, trying to do was also make sure that we were not incurring ongoing storage costs, which would have also cost the taxpayer significant sums. So clearing the decks, if you like, would have been a priority at that time.
And looking at, this is my final question, around equipment and PPE overall from COVID-19, is there any work ongoing to extend the life of the inventory that you have and its possible uses?
Yes, so I mean, we do that across all our inventory, whether it's PPE or vaccines or antivirals. That is one of the key things we look at, extending the shelf life for as long as is absolutely possible while retaining sort of health and safety concerns.
Thank you. And obviously we touched a lot on the fraud issues repeatedly. So I think, Ms. Dunn, you'll be the one who's been leading on this. Not particularly, well, whichever.
More than happy to share.
Just want to make sure I'm directing questions. Yes. So we've previously looked at a number of contracts that are still in disputes. Can you give us an update on what number we're at on that? That's obviously not all fraud or crime, but what number are we at now?
So the dissolutions team is the team that does this. Chair, as you know, we've discussed this with you before. The number referred to in the accounts at March 23 was 45 contracts that were still under review. That number has come down substantially. I think that number is now under 20, but I won't comment on the precise details because we're
so we haven't got the exact figures, but we recognise that because these accounts are delayed, it's just helpful to know what the trajectory is.
Indeed. So that work has continued at pace. We've and the accounts refer to the sums of money that were both avoided fraud and recovered, and we've continued to work through contracts, which, as you say, as you know, are mostly not at issue for fear of fraud, but there is some level of dissatisfaction with the contracts as a consequence of our review of the materials.
I mean, how would you describe in simple terms how that's going? Are people saying, yeah, we gave you the wrong stuff, we're now going to give you the right stuff, we're trying to get, because obviously there's a sort of two layers to this, aren't there? There's getting the public money sorted and the deal for the taxpayer, but there's also that if people were doing the wrong thing during a pandemic, there's lessons that ought to be driven home on that. So where are you drawing that line, and how are you finding the negotiations?
As you'd expect, it's a mixed picture. I go through this in some detail with the dissolutions team from time to time, and have done so very recently. I think it is fair to say that in most cases now, what we're talking about is materials that weren't quite up to the standard we expected them to be, or were for some technical reason missing information, documentation, etc. But where we identify that people were effectively attempting to profit at the expense of the taxpayer, we take a very, very firm hand and we pursue that.
Okay, so how many are you pursuing on fraud? Can you give us, even if you can't give us a specific ballpark?
Yes, Chair. I'm reluctant to give you kind of specific numbers because obviously a lot of these cases are very live, and so those negotiations.
Small sample could be identifiable. Because we'll continue to pursue this obviously and in public as much as we can.
Yeah, I think.
And I'm more than happy to provide.
Can we have a private briefing at the end?
Why don't we provide you with a private briefing on specifically the fraud?
Because I think what we want to do is shine sunlight on this in the public domain, but I think the public would also want us to know that somebody's looking at what's going on. Notwithstanding, I'm sure you're trying to do your best to get this back and take on the fraudsters, but a bit of scrutiny of that doesn't hurt. That's what we're here for. So in terms of when will you be reporting, when will you be in a position to report to Parliament and the public what the level of fraud is that actually materialises?
Okay, so I think we have said, Chair, that once we get, at some point, we will reach the conclusion that, if you like, the returns, we will go after every penny that we possibly can when we think the taxpayer is being defrauded, certainly. But at some point, we will get to the point where the sort of diminishing returns and the cost of the exercise is greater than the cost of the return, at which point we'll sort of make a decision to close that team. And at that point, we have said, at the end of that process, we will report on the overall outturn of that effort to Parliament, and that's absolutely. But I can't tell you when that will be yet because we're determined to keep on going after.
So are we talking months or years at this point now? Down to about 20?
I would expect we're talking months, Chair, rather than years.
That's helpful though. So we'll keep a beady eye on that. And then we've talked a bit about this before, but now you're at this stage. Mm-hmm. What lessons do you think that you would, if you were advising someone in a future pandemic, what lessons would you have learned from now you've trawled through all of these contracts to see what's gone wrong, both fraud and error? Chair, we have spent, as with some of the other things we've discussed today, we've spent many hours on this in committee, haven't we? And the things that we have. You're at a stage now, a maturity of understanding, because you've gone through everything with a fine-tooth comb.
To be fair, I don't think that the work that the team have been doing to go after money that should be returned to the taxpayer has elicited any further lessons other than the ones that we had previously discussed, and we know what those are. But those are extensive lessons that have been covered in the Boardman Review and elsewhere about how you procure in circumstances like the ones we were in. I don't think there are any new lessons. And to your question, which I realised I didn't answer a moment ago, in terms of the level of fraud, overall fraud within our PP purchase, I don't think there's anything that we're seeing that is changing our previous assessment that it was around about the sort of 1.8%. We'll report on that at the end as well if we've seen any significant difference.
Mr. Brittain, you're the money man who'll collect the money in if it's recovered. Have you got anything to add about estimates about what you might be able to collect and what you've collected so far?
No, other than to say, of course, we pursue where it's reasonable and the right thing to do, pursue every pound we can to get this back, get the money back.
And is there anything about the speed at which it's done? I mean, we recognise it was obviously a lot of money spent in fast measure during the pandemic when we've gone through all the rights and wrongs of that. But the slower it takes, we know this through all the work we do and you do too, that the longer it takes to chase down any payment, the harder it is to find it if someone's deliberately really trying to defraud in the system, defraud the system. Is there any lessons you've learned, Mr. Brittain, about what the pace at which we should be doing this work?
I think the contracts resolution team has been doing it at a very significant pace, and Ms Dunn has set out the extent to which the outstanding contracts have drawn down over time. I think the ones that are left are probably the more complex cases, as you described. So I think they have done this as quickly as possible, but it's the easier ones that have been resolved first.
Yeah, and I mean, as you know, Chair, there's sort of a huge balancing act going on here, because you're completely right that the quicker the better, but we want no message out there that you can basically time the government out and all you've got to do is add complication and etc. etc. We want the message out there that we'll pursue every pound, as it were, quicker the better, but also as long as it takes, and you're not going to get away with it simply by delay.
Yeah, I mean, my point about quicker the better
is
that people disappear into the sands.
No, exactly.
Really
we completely agree with your point, but you need to do the sort of double thing of quicker the better, plus you don't get away with it just because you time it out.
And I did. I'm going to try and ask the question again. Was done, or maybe Sir Chris, another way about how many cases you were taking to court. Just see if there's any number you can give us. We know there's one high-profile case, which we won't discuss here.
We'll give you a private
Okay, that's a private briefing. We'll start with that, and then I assure
yes.
the public we'll take as much into public domain as we possibly can when we can.
Yeah, and of course, and you've said this before, obviously in retrospect we can put a lot more in the public domain than we can while these things are in flight, where we have to keep it private.
And you will pledge to do that to Parliament?
Yes.
Okay, well, we'll want to talk to you about how you present that as well, because of course we've got things like elections coming. We're already 4 years on from the start of the pandemic. People forget why we might need to know these things. We'll keep a beady eye as a committee. Thank you very much indeed. Sir Geoffrey Clifton-Brown, Deputy Chair.
Thank you, Chair. Good afternoon, Dame Jenny Harries. You inherited a poison chalice, being the Chief Executive and Accounting Officer for the UK Health Security Agency. I'm going to call it DHSC from now on. Unfortunately, your organisation has had its accounts disclaimed for the second time, 2 years running. And I think even the disclaimer hasn't happened for any organisation in the public sector for the last 20 years. So this is a highly unusual occurrence. So you will forgive me if I ask you and the man in charge of the numbers, sitting next to you, Andy Brittain, some quite searching questions. But firstly, can I ask you, because this really goes right to the overall organisation of it all, is there sufficient organisational understanding and acceptance at the level of cultural change and control improvement that is required to fix the issues, which I shall be going through in a minute in detail, because they are quite deep-seated and quite serious?
Yes, of course, is the short answer. And I wouldn't want to be running an organisation any longer than I can with an accounting position as it is. It's not where we'd hoped to be this year. And I think I would just like to draw a distinction between last year's disclaimed accounts and this year's, because I think they're quite different. And you may wish to go into both sides of those. So I think for last year, we were a new organisation. I think, as you've alluded to, we inherited a number of issues coming into being. We came in mid-year on the 1st of October 2021. We were given a new accounting system on the first day that we started, which is probably not what you would normally do. We arrived in the middle of a pandemic, and many of the issues we've just been talking about, various contracts and things that we now control or oversee, were given to us. They're not ones that the organisation itself controlled. And nevertheless, I think from what you'll see from the NAO report this year, for what we had put in place to try and pull ourselves out of those disclaimed accounts last year, we've made very good progress. And I think that is clear in the board. That doesn't mean we are complacent at all. Absolutely recognise that there are cultural issues with all organisations. But just perhaps to flag a few of those issues, one of the difficulties last year was, for this year's accounts, we came in with very little headroom because of the disclaimed accounts last year, and then we've had a separate issue with the COVID vaccine unit and the model, which we can come on to. But I think in terms of what we've done last year to put ourselves forward, I myself chair a Finance and Control Improvement Board. It has representation from NAO, from DHSC, from GIAA. We have an ARC in place, which was not there fully formed at the start. We were a new organisation without all the right parts of the system. All of that has been put in place, and I think you can see that in this year's accounts. What has happened this year is a separate issue relating to the COVID vaccine unit, which I'm very happy
I'm going to come on to
highlight.
that. But I'm going to ask you, Sir Chris, given that this was an organisation that was new, it had a new accounting system, it was in the height of the pandemic, why did you add to that organisation additional huge responsibility of transferring them the COVID vaccine unit in the 1st of October 2022?
Yeah, so our starting point, well, actually, I'm going to say a couple of things about UKHSA as well, but I'll answer your specific question first. Our starting point is the health protection function and what makes a successful health protection system. And I should put on record that on that side of UKHSA's operation, we're extremely pleased with how the organisation has been established and gone forward. It obviously did the end of COVID, but it's also done some other very significant health protection work around monkeypox, around MMR and measles, which is exactly what you want to see on the real purpose of the organisation, the science and the health protection work. And our starting point is always that. So you take the issue of COVID and COVID vaccines. Vaccination, as you know, is absolutely central to health protection, both across COVID, flu, and everything else.
Why did you transfer it to an organisation that was new and struggling?
Because they are the people who are very good at health protection. So who should be taking the decisions about vaccine deployment, about how we use them, how that interrelates with the flu programmes that UKHSA already had? That should be our health protection experts. So in terms of getting successful vaccine deployment, it's a complete no-brainer that should be in UKHSA. It does leave us with the issue that you're identifying of a new organisation that has quite a lot of systems issues on this side. We always take the view that we're not going to do something suboptimal on health protection on those grounds. So if there is pain to be taken, we take it on how we, the public servants, have to account for it, not on the population and how its health protection is taken. We took the view that we had to transfer the money and the accounting officer responsibilities at the same time. It's really bad practice to have the operational decisions taken in a separate organisation from the accounting officer. So once we decided that the best operational decisions are those made by UKHSA in line with its other responsibilities, the accounting officer responsibilities and the financial control responsibilities go with that. So that's the basis of the decision, and frankly I still think that's the right decision, to start with what makes good health protection and then deal with the other issues. But that was the heart of the decision making. And then the other general point I wanted to make about UKHSA, and I think we've discussed this, but I think the CNAG agrees with this. We have seen significant progress in UKHSA on its base financial systems and its culture. You're not shaking your head at me, so I think that's the thing. So we are on your very important first question on are we creating the right culture to move forward. We fundamentally think yes, and the evidence we've had from the NAO.
Yes, I'll just bring in the CNAG on there. I think
yes. Just to respond to that point, I mean, I absolutely agree that quite a lot of really important governance arrangements were introduced following the first year's accounts, including the operation of the audit committee, and that's made a big difference. There's been progress on being able to present a more manageable set of financial data for us to audit. But I think on that one there's still a long way to go, actually. Yep. So although it was better, it was going from an extremely challenging position to a challenging position. And so there's still, I mean, I think a really crucial success factor here is not underestimating what remains to be done, and therefore allocating sufficient resources of the right expertise and so on to continue that cleaning up of the financial ledger, the ability to respond promptly to audit queries in a kind of pressurised timetable, and all of those kind of nuts and bolts of a normal accounting process.
Fortunately, you've said exactly what I was going to say in the second part of my answer. That is not the same. I'm very,
Can you repeat it then?
Yeah, I'm not going to repeat it. So that is not the same, as there isn't still a lot to do and a lot of things to fix. But I was on your very specific and correct point of have we got an organisation with the right culture that is seeking to make the improvements that it needs, even if it hasn't got all the way there yet. And I think that's where we agree.
Right. In order to test both of your answers, Dame Jenny's answers and yours, Sir Chris, I'm going to go to the money man, the figures man, ask you several very specific questions, if I may, please, Mr. Brittain, and thank the CNAG for his very helpful intervention there. So we talked about the CVU team being transferred to UKHSA, but your finance team also uses the outputs of the CVU model, demand model, within its own accounting model to provide the impairment and provision figures in the annual important accounts. Given the significance of the model to the accounts, this is the CNAG identified it as a key audit risk when planning his audit. What have you done to remedy that?
To remedy the key audit risk?
Yes.
So So the issue for this account occurred because the AXA CDU team switched from their primary model to a backup model, which had been cross-validated in numbers. The issue is that the NAO couldn't then audit it sufficiently in the time that was left remaining available. This year, to remedy that, we are putting in place a detailed plan, which we've agreed with the NAO, to go in and audit the COVID vaccine unit model much earlier on in the audit, so that we have assurance that it is auditable and it is fit for purpose. We're also putting in extra resource into UKHSA to enable the information to be there, ready when the NAO go in to audit it.
Could I perhaps build on that a little bit, because clearly I'm nearer the detail of the organisation and very much value Andy's oversight of it. So I think there was a model. It was a Python model. Exactly as Andy said, there was a validation model as well. Both of them were sitting within the same governance structure. The particular point that triggered this issue was the fact that, picking up, I think, Sir Chris's point, which is there was a change in the variant. Now, all of this happened after the end of the financial year. So I think the point here is it's about the model. We switched, or the COVID vaccine unit switched. They needed to forecast for public health reasons. They took that action. It was known to our finance team, but I think exactly as Andy said, the alert to the NAO came in November, which was too late then, I think, to go through the assurance process. But I think there are some other actions that we have put in since, which was the point I wanted to pick up. So one is there is a business critical model definition has gone in. We already had an analytical quality assurance framework, but we have gone back over that and completely resourced it. We've got a registered analytical pipeline, a RAP plan, which we've implemented as well. So there are a whole host of things, all consistent with the Aquabook, with McPherson Review and various other things that have all been put into place to make sure that that cannot happen again. But it was largely a communications issue rather than there being, as yet, and I realise the NAO will want to quite rightly ensure that is the case, that there is no suggestion that the actual model has failed us in this case. Indeed, we had to change, I think, the output again the following months because of the variants.
Ms. Harries, can I press you a little bit on this matter? Dane. Given that you said that you think the control improvement has, you've now improved it considerably, the CNAG reports on your accounts on page 138, UKHSA changed the model it was using, and key stakeholders, including my audit team, were not informed of this change on a timely basis. Surely, when you make a significant change like that, the first thing you do is tell your own financial team and the external government auditing team what you're doing, and you didn't do that on a timely basis.
So I think that's what I was trying to explain. So absolutely, that is exactly what should happen, and we recognise that, and we're absolutely committed to ensuring that the model is reviewed and that we have, and as Andy said, we have a time frame set out to do that going forward into next year. But I think in this case what happened, we had finance business partners in a governance meeting, which we also asked external DHSC colleagues to review afterwards to check that the process was okay. The communications issue was between the business partners who were in the meeting and our central controls teams, who did not realise that the change in methodology, or rather the change in model, given that they were on the same methodology, was a material change, and I think that's where the problem lay.
Yeah, and sorry, just to be clear, Sir Geoffrey, I mean, no one is denying this was a mistake. Yeah. The CNAG's words, as you read them out, we all agree with, that clearly that should have been notified to the NAO earlier, and that would have helped with some of the problem. And this isn't a pedantic point, although it sounds like one. On your words of what we do, that is not the first thing we were doing. The first thing we were doing was focusing on getting the right vaccine into the right arms for the variant that we had at the time. We should have done exactly what the CNAG says in the report, and I say we agreed it as well. But as I say, our first focus was on getting the right vaccines into the right people at the time, as it were. But as I say, categorically, CNAG is correct. A mistake was made, and this is the result.
Yes.
Thank you for that admission. And and thank you for the action that you're taking, and I've no doubt the AJ will look at that very carefully when he looks at your next set of accounts. Maybe to you, Mr. Brittain, given the extremely large size of the CVU balances in relation to UKHSA as a relatively small organisation, UKHSA will therefore ensure an additional layer of management review is introduced at an earlier stage. How are you doing that?
Sorry, I missed the second half of your question there. Sorry.
Given the extremely large size of the CVU balances in relation to the UKHSA as a relatively small organisation, will UKHSA therefore ensure an additional layer of management review is introduced at an earlier stage?
I see. So, yes is the answer. So what's happened is that...
Probably all we need.
Okay, right. That's simple.
The late post-balance sheet events, as described above, and consequent changes to our accounts have resulted in it not being possible to provide required assurance of these balances in advance of the 31st of January statutory deadline. Can you give us an assurance that the necessary infrastructure is in place, particularly financial oversight is in place, to make sure that these post-balance sheet events don't happen again this year?
So I can't guarantee no post-balance sheet event will happen, but what I can, because as Dame Jenny set out, that sometimes relates to COVID variants which are out with our control. But what I can say is that we have put in place much more rigorous governance and controls around the accounts and models and the ability of the accounts team and the finance team to engage with the business. And we have a detailed audit plan which we agreed with the NAO to get this year's audit done to a good time and flagging issues early. So I think we've put in place really quite significant improvements which should mitigate that risk very significantly.
Well, that's quite... Yeah, can you just give us a bit more specifics on that, particularly on resources and people, to make sure that it doesn't... Because this is a really serious matter. We don't want it recurring. What resources, what people? For example, wouldn't a chief finance operator within UKSA be a useful addition?
There's three things I'd pick up here. One is that the core UKHSA finance team has been recruiting and building its capability and capacity, and that is coming on well. The second thing is, given the significance of this year's audit and the amount of work we need to do, which, as I said, we've agreed a detailed plan with the NAO, we are putting in place some external assistance to get in, front load and do all the really hard work on cleaning up the information and being able to provide it to the NAO in a very decent state. Thirdly, as you alluded to at the beginning, we've codified my role in UKHSA, which is to work with Dame Jenny and ensure the finance team and governance and controls are of the right standard. I can go into any of that in more detail if that would be helpful.
I do accept that, but that's not quite the same thing as having a high-powered chief finance officer within the organisation who can actually nip all these problems in the bud, rather than you sitting in the department actually looking at them from the outside.
UKHSA does have its own chief finance officer, I should say, and a finance director.
Right.
Yeah.
But I think Sir Geoffrey's saying it's suboptimal. I mean, we've seen situations like this before where there's oversight. It does happen. But when would you expect UKHSA to be standalone with Dame Jenny having, Dame Jenny, when will you have the support? And have you thought of having do you need any other executive roles, chief operating officer, that kind of role underneath you? Because you're the expert, but they are running the organisation.
Absolutely, and I recognise that. And I think actually I would see Andy in the department's role as an additional layer of both support and critique and challenge to what we're doing internally. So we do have...
How long? How long are you expecting to continue?
Well, I'll just go back a little bit, because at the start of this year, our whole workforce was very unstable. We only had 30, going back at the start of that financial year, 30% of our
This is the beginning of, just to be clear,
of the accounting year that we are considering.
So.
We only had 30% of our workforce stable. So when Andy said building a new team, we're now up to around 83%, I think. So the whole culture and system of the organisation, so just putting in place a stable workforce moves us forwards into a position where you would expect the organisation to be operating. We do have our own chief financial officer. We also have our workforce rated not only within the financial control and improvement plan, but it's actually on our strategic risk register as well to make sure it's prioritised. We also have the things which I think we're talking about the basics here as well. So I think we've spoken about the model, but the absolute basics, which I think are what CNAG is particularly referencing and how we move forward, are things like getting our workforce data right. That's progressing phase 2 of MAPS. It's things like getting our purchasing processing right, and those are very much focused. There is a challenge around workforce capacity, or there has been. I think we are now up to roughly the right numbers. That was not the case, I think, when we were stabilising the organisation. It was a huge churn.
I'll add 2 things which are pertinent to your question. So one is, as the vaccines unit demonstrates, there's actually quite a lot of traffic between the department and the agency, and therefore having a single person who oversees all of that has positive advantages. In an ideal world, and we're not quite there yet, oversight from the department will never stop, but it will be more in the same sort of relationship as the department has with the Treasury. We would have that relationship with the agency, so that it's genuine oversight as opposed to being in there doing the work. But there is no circumstance in which that oversight will stop, because of course the external oversight is useful to the process in exactly the same way as Treasury oversight of us is useful to the process. So that's the end state. I think we're not quite there yet, but that is the role.
So we're away from between then.
Yes,
it's always oversight, but this is a bit more day to day. So So Geoffrey, do you want to continue?
I mean, you wouldn't normally, Sir Chris, have this degree of oversight of one of your non-departmental organisations within the department. So you wouldn't. You wouldn't have your chief finance officer sitting in the way that he is over the top of it.
In its setup phase, I mean, very important, of course, this is an executive agency at the department. These are other civil servants. It's formally part of the department, so it's not like our relationship with NHS England, which is a separate statutory body. In its setup phase, no, it's not that unusual. That is a thing departments do when we are still in, as it were, the setup phase of what is a very complicated organisation. Your fundamental point, I agree with. If we were still in this situation in 2-3 years' time, then something very badly has gone wrong, because we would expect UK HSA to be doing all these things for itself. But in this circumstance where you've got a new and complicated organisation that's a merger of 3 very complicated organisations and has very complex day-to-day health protection responsibilities, I think it's fair enough that we are giving UK HSA extra assistance as it gets through that phase. As long as that's a phased thing, I am happy with that situation. I don't think I or Jenny would be happy if that was still the situation when, as it were, we're coming out of the set-up phase and into this is an established organisation with its own systems.
I hear that argument. Given the effect that this part of your organisation has had on the qualification of overall departmental accounts, which cannot be a good thing, it's had 2 years to sort itself out. You talked about another 2 years.
No, I was talking about the oversight and the extensiveness.
Okay,
of the
let me rephrase the question then.
Yeah.
Are you confident that in the next financial audit that the accounts for this organisation will not be qualified?
Well,
no, they absolutely will be qualified. I think the question is whether there'll be another disclaimer or not, disclaimed opinion or not, and we're working extremely hard to avoid that circumstance. What I would add to Sir Chris's point is that, and Dame Ginny's point is that the first one was largely related around financial controls and governance, which has largely been rectified.
Head over into the second one.
It reduced the amount of sort of headroom we had to avoid a disclaimer, and it's unfortunate that this COVID vaccine unit issue emerged late in the financial year. We're working as hard as we can to rectify that. So I hope and I anticipate we'll be able to avoid another disclaimer. I can't guarantee that at the moment because we have 10 months of work to do with the NAO to get through the audit.
10 months is quite a long time. I mean, a qualification is one thing, a disclaimer is a totally different.
Yes, I know, yes.
surely within the next 10 months, you ought to be able to work this through so that at least you've got a reasonably reliable set of accounts that the CNAG does.
Indeed. So we are throwing absolutely everything we have at this. We are, as I said, we're getting external assistance, a team of external assistants in to scrub the data and clean it and make sure it's in to a standard that the NAO can go in and right first time audit it. So that's what we're doing about the core financial information. We are getting some separate people in to ensure the COVID vaccine unit model is able to be audited cleanly and quickly when the NAO go in. However, it remains the case that given the history of the organisation, the history of the COVID transactions going through it, it is far, far more complicated than any other ALB would be.
And just to be absolutely clear, I mean, we never guarantee in advance. It's a decision for the CNAG. Yeah. The CNAG, for obvious reasons, does not commit himself in advance, and we don't second guess the CNAG's
You're doing your best.
So we, as Andy says, we have to throw everything we can at it. The answer to your question goes to our friends way at the end of the year, and we don't try and second guess that opinion in advance for obvious reasons.
So, Jenny, you took this on in midway through a financial year. You're an expert in the medical field, but looking back, do you wish you'd asked for certain other support or help, or what would you do differently now if you were asked to take on a body like the DHSC? Well, what would your advice be to anyone doing the same thing?
Well, for the very reasons which Sir Chris has said, I would take on exactly the same, because we're trying to do the right health protection issues to the population. And I think what we have described here is a very unusual set of circumstances arising from a pandemic. There are clearly management control issues, and I hope we've described those satisfactorily.
What would your advice be if one of us was offered a job like this and a new organisation said, what would be your top tips to someone coming in with the professional medical expertise but not necessarily taking on a new body?
I don't think one should assume that because you have medical skills,
you
don't have management skills.
I didn't mean to put it across that way at all. But what I mean is that you were brought in mainly because of your medical expertise, yes. I imagine. And obviously running an organisation is not new to you, but this was a very complex organisation set up at pace, and your priority, as you say, was protecting the health of the nation. But there's an awful lot
also
of stuff
to build
behind.
A stable organisation with opportunity. And I think the answer to your question is, firstly, ensure that the ground bits are in place as early as possible. And not all of that is within the organisation's control. It's quite complex to set these things up and get all the right boards and people appointed, even though that was sort of early. So do everything as early as possible along that stand side, but also actually articulate ahead some of the potential issues. And you're picking up Sir Chris's point. When I was here last year, I said this is going to be at least a 2-year journey. I think it's going to be, it's 2 to 3 years with the point we've just been discussing. But I'd also just like to flag that if there is another big health protection issue, or for example, where we are doing what it says on the tin for the UK Health Security Agency, which is working with pharmaceutical companies, building new opportunities in the life science agenda, that may in due course, and it all needs to be governance properly, put an organisation in a different position. So I think there's a balance point about recognising exactly what we must do in terms of financial governance and control, but also flagging some of the potential problems that come ahead. If we have a mid-year.
No, exactly. That would be my one too. I mean, we weren't really thinking about it because obviously we're at the beginning of the pandemic, but in retrospect, if we're doing it again, we should have been much clearer at the outset about the pain to come, and much more explicit that we were going to take health protection decisions first, and then we were going to do our best around.
We appreciate your candour, and I think it was only want to probe a bit of it.
So that is what we did. We could have been very explicit about that right at the beginning. As I say, it's not surprising that it wasn't, because that was not what we were thinking about in when we set this organisation up. But I think that's the learning point.
Okay, well, thank you, Ms. Owen.
Thank you, Chair. On that, I just want to pick up on some of the points that Sir Geoffrey had made and some of your responses, Mr. Brittain. You talked about rigorous models of accounts, a detailed audit plan and significant improvements. I just wondered, specifically with tackling optimism bias, what some of those significant improvements are.
So for this year, we have in establishing the audit plan, we have worked much harder and much more comprehensively up front with the NAO to agree what we both consider to be a realistic audit plan is, which includes elements of contingency in case things go on longer than we would hope to. I think that's the key fundamental thing, really, because last year was, we had a plan, but then it was a bit of a voyage of discovery as we went through the year. I think, particularly given the COVID issues, this year we kind of know what the issues are. So we have got that plan in place, which is more credible early on. As I said, we've thrown extra resources at it. In the department, I've got a monthly board which with the NAO, where we jointly take stock of progress against the overall department's group audit and the component bodies audit. So that's the NHS particularly and the UKHSA. So I think we've got sort of a better plan and better governance in place this year to enable a better chance of success here.
Great. And is that part of the culture change that Sir Chris was alluding to? Is there much more challenge within the department itself?
I think there's more realism. Yeah, I mean, I think as Sir Chris mentioned, for last year and certainly the year previously, the consuming focus was on the response to COVID. Of course, we knew we needed to improve controls and governance very quickly coming out of that, and we've previously talked about the finance reset programme that went on in the department. I think as we go through that, you see increasing levels of realism and improving governance and controls, and where issues continue to emerge, we take quick action.
And would you accept that there isn't any other kind of organisation or department that would be able to operate properly without that degree of realism? And is it a little bit of a shame that it's taken this long to realise that that realism is needed and necessary to plan for the future?
I mean, again, I wouldn't characterise it in that way, because for the last 2 years we have been primarily responding to COVID, and I'd contend that it wasn't, that was such an uncertain and volatile disease that it was, I certainly wouldn't know how to be realistic about that, the course of it and the impact on the organisation, because it was just evolving and emerging.
I don't know what Jenny thinks, but I'm not sure optimism bias was the heart of the problem. I think people knew how tough it was. It's the absolute challenge of getting it over the line that's been the difficulty. Certainly I haven't detected people being over-optimistic. It's the level of the challenge.
And if I could perhaps add to that, I mean, I hope what you hear is absolute recognition of what we need to be doing as an organisation, but also the challenge, I think, was about what else we were having to do with a new organisation, with an unstable workforce. And I think we started the conversation with culture, and actually you need people to be on board with this. And that also is a really critical component of effective governance systems, and that takes a while to bed in and progress, but I think it's moving in the right direction.
Thank you. And I think on those points around culture and workforce, Dame Jenny, could I just ask, your point around there was a lot of unstable workforce, transitional workforce at the start of 22-23. How much of your exec team are permanent UKHSA staff members rather than secondees and people on temporary contracts?
So the executive team are effectively all permanent, but just to qualify that, there are a few on long-term secondments because we thrive effectively. We are based on our technical expertise. So, for example, we have an academic executive on a long-term secondment. We have a clinician on a long-term secondment, but these are 3 to 5 year appointments. So effectively, they are permanent. Okay.
And that's a small percentage of your team, or would you say it's a significant percentage?
No, it's a minority percentage. We have one post where we're looking clearly, as with other government organisations, we are trying to be efficient, and we are slightly top heavy as we come out of the pandemic, and we're actually looking at how we can make our spans and controls a little bit tighter but remain effective.
Yeah, and the small percentage is a good thing, not a bad thing, and we do this in the department as well, particularly when we're taking on scientific staff. We are very frequently taking secondments from universities or from the NHS itself, and that's a very positive thing as long as it's long term, as it were.
I mean, throughout our workforce, we have what we call double hatters. So with academia, a couple of hundred, I think, double hatters of people who are working half in the organisation and half in academia, and that's beneficial because it helps work with industry, work with academia as well to progress innovation.
Thank you. And a question to Sir Chris and to Dame Jenny on that point. You talked about a culture of trying to move forward and workforce, and one of the rigorous and significant improvements is around diversifying the workforce as well and the experience within it. It's not just, I would say, the experience and skills. When it particularly comes to something like COVID-19 and the health inequalities that this country is facing, it will be ethnic minorities that are particularly, and low paid members of the community that are going to be increasingly vulnerable. What are you doing to ensure that expertise and real life experience is actually accounted for, and whether there is any moves within the department to see much more diversity within the top levels of your teams?
My answer for UKHSA to start with. So I absolutely recognise that. I take the view that unless we have diverse decision making and all the right inputs, we will make the wrong decisions. That's particularly important if we're trying to design services or supporting services. So we have a strategy around health inequalities, which we challenge ourselves to deliver on all of the work that we do. So we're gradually trying to increase our data flow so that we can evidence that. But I think importantly when it comes to workforce, so we have a group looking at health inequalities. So, for example, it looks at infectious disease in prisons or infectious disease in homeless people, and we have a group with that. But I think importantly is the issue about ensuring that we have representative people at senior level. Now, I put in lots of particular process issues around recruitment. We're not very representative at EXCO, but as you go down one layer to our senior directors, we are, and we've got an Accelerate programme as well, which pulls through good individuals from particularly from ethnic minority but or disadvantaged backgrounds, so that we can promote them and support them into roles of leadership within the organisation.
Just explain what the Accelerator programme, how long people have to come in for.
Broadly it's a year programme as it stands. I mean, there are variations of it, and we
rate like secondees for a year.
Exactly. So it will be people coming in. They will be attached to one of the Director Generals, for example. They will get exposure to senior decision making so they can see from a different perspective, and they're supported on an individual basis to ensure that they are comfortable in that role and they have all the support they need to be there. And it's been hugely successful so far in doing that. We have higher, as you come down the system, it's our very EXCO level that's not quite so good. We've got actually very good representation above population average across our staff.
And in terms of that secondment process, and as you say, coming down a level, does that level where you do see an increase in diversity, do they feel comfortable in challenging up?
I hope so. We have, I mean, again, we're still quite a new organisation to get this right. We have a senior leadership team. We're trying to start to delegate more responsibility down, but also we have values for the organisation around being insightful, impactful, and I'm now going to forget my third one. That always happens. Inclusive, it's exactly the right word.
Guys,
inclusive, yes. But actually, we did find that when people come in to present papers, for example, at the executive meetings, there was some suggestion that people didn't feel comfortable or they didn't feel true, so we've actually put in a process to encourage them to anonymously feed that back in, and then we do a stock take each time to try and review how that feedback is looking.
So you're asking for feedback from staff as to how that's
people who come into the Lexio, to actually, are we welcoming to them? Are there problems with, does it feel a hostile environment? Do they feel able to put their case?
Yeah, and then for the department, we do well on our diversity indicators, but not well enough. So we do very well indeed on gender, where we're 50-50 pretty much across the organisation, including right at the top. We do less well on ethnic minorities, although because we draw on the fantastically diverse NHS, we actually have some of the most significant thinkers on this subject. And you mentioned the COVID experience. A lot of the most important thinking done by Professor Kevin Fenton and his report, and Professor Van Tan and his work on vaccines, both of which make your point. But it does mean we have, actually some of the most significant figures in the country working with us. What we don't have is the breadth. And then actually we do worst, and this is something we really do need to work on disability. So that's the area. So we tend to be at the top of the government benchmarks on pretty much everything, which we should be given the sectors we draw on the type of department we are, but it's mixed across the protected characteristics.
Ms. Owen, can I add from my point of view, going into the senior civil service, our succession planning and our pipeline into the senior civil service is something we're really, really focused on across all of those characteristics, as Chris has said. But we're also really interested in geographical diversity and socioeconomic diversity as well. So, kind of our focus on Leeds, developing Leeds as our second headquarters, and making sure that we've got that we're really making sure that we've got a good coverage across the country is important to us too.
Well, I would just observe that Kat Little's just been appointed a latest permanent secretary, and on our reckoning, it's about the 57th woman ever to be a permanent secretary.
Yes, and I think
we're
it's
intending to take a photo.
Yeah, but I think
so. I mean, this isn't a great record, is what I'm saying.
No,
so let's not overblow. And that's just men and women, let alone the other.
Yeah, but I mean, the numbers are even more extraordinary when you look at them. So I think it's about 20 at the moment who are a permanent secretary, and 57 in total.
Yes.
Which demonstrates a lot of things about the journey.
Yeah. I don't think so. Let's not be too dance a jig just yet on how things are going. But just on the overall issue around the accounts in the UK HSA, I mean, I think it's pretty obvious from our questioning, and we've obviously challenged this last year as well, that to set up a new body, partly all the challenges of mid-year, and obviously we know about the pandemic, but that's still not an excuse not to have proper financial controls. And so, this is just the bread and butter of what Whitehall should be doing, what accounting officers should be doing, and making sure that organisations are set up with the proper arrangements. So, we've made our point, I think, on that. But and the CNAG obviously make his own point. But so Chris, you must acknowledge it was
what I was
thrown
going to
together. Proper controls were in place, and that's partly why we are where we are.
Yeah.
Now,
and
we can't just blame the pandemic.
No, and I'm not going to. So what I'll say is, I completely defend the decisions we took organisationally based on health protection. I also hope, and it was certainly our intention coming here, that we have been blunt about what went well, what didn't go well, and things where we made mistakes. So we go into this with that philosophy, and I hope that's what's come over at this hearing, that we do think we've done the health protection bit very well. We do think we've made progress, and we also recognise everything the CNAG says about the progress that still needs to be made. And I hope we've been blunt about all that.
Well, I mean, as accounting officer, you're accountable, and
yes.
Indeed, Jenny is to this committee, to Parliament through this committee. So it is important that we get those financial basics right, and we know what happens when those controls go awry. We won't revisit all of that. But I'm now going to turn to Jonathan Ginocchia.
Thank you, Chair. I'd like to talk about suspension payments. So I'm looking at the accounts, and it says, under certain qualifying circumstances, NHS England can make suspension payments to medical practitioners who've been suspended as set out in relevant statutory regulations. And then it goes on to say, NHS England has not recovered most of the ineligible suspension payments it made. Ineligible suspension payments made to 2 of the 12 medical practitioners have been recovered in full by NHS England. These recoveries amount to £32,747. The remaining £1,302,879 has not been recovered. NHS England is taking legal advice regarding recovery. Mr. Kelly, why don't you have adequate financial control over these ineligible payments?
So in late 2022, when we were doing, the NEO were doing the audit of the previous accounts, they identified 2 cases where payments should have been suspended and they hadn't been. I then commissioned an internal audit review of all of the people who are on the list and still the suspended list and still being paid, to make sure that there were no other cases. In that review, we identified 12 other cases. Those are the cases that are in these accounts. Those have all been sorted. We have not found any others. By the way, we're going back through the list again, and we have changed our control regime. In particular, this was being done by 7 different regional teams. They are relatively rare cases. Actually, some of the case law is quite complex. We have decided to create a single national team who do it, the same team who are doing it all the time, so we have better oversight, can make sure it's being done properly, better control, so we don't find ourselves in this position again. And as you flagged, we are still seeking to recover more of the overpayment. I don't think we will recover it all, but we are still seeking to recover more of the overpayment.
I'm pleased you clarify that, because actually the accounts don't say that. The accounts say that you're taking legal advice regarding recovery.
We are making sure we're on legally. We are making sure we are on legally sound ground to pursue recovery in all. I just need to say.
And you are pursuing recovery,
Yeah.
are you?
Yeah.
In all cases?
Well, there are one or two cases where we're just confirming, but it's possible we won't be able to because of things that were said and done in the past. So that's where the kind of legal advice is being pursued to make sure we're on legally sound ground to pursue.
And are there procedural measures that you're putting in place so this doesn't happen again?
Yeah, as I said, we have reviewed the whole caseload once. We're currently in the process of reviewing it again to make sure we haven't missed anything. And we are creating a single national team who will now do this, as opposed to it being dispersed through 7 other teams.
And that will stop the problem?
Well, yes, I am hoping it will stop the problem because we'll have one group of people who are doing it the whole time. We can make sure that nationally we can really check every single month, and we streamline
Can you just
the
talk through what will
process.
happen? So you've got one team, but you've still got all of the different trusts. It could be people spread very wide.
No, it's it's largely to do with GPs. I mean, it can be to do with dentists as well, but in this particular instance, it is GPs. And in essence, there is a process where you have to check for those who have been suspended almost every month. Are they still
Exactly.
employed?
So that's what this central team will do differently.
Yeah.
They will ring up the GP practice and check, or ring the individual and check.
Or they will review where they are
with.
with the General Medical Council and whether they are in their process. And in some cases, the judgment is reasonably complex, so I just want one group of people fully trained.
I understand that. Thank you.
Thank you. Thank you very much, Mr. Ginocchly. Sir Geoffrey.
Dave Maker. Can I turn to you again, Mr. Brittain, as the money man, and raise another whole serious financial issue with you, and this is the lateness of auditing some of your local bodies, and in particular on page 130 of your annual report and accounts, on paragraph 540. It says there is this small but significant number of CCG and ICB audited accounts that were significantly late has delayed the preparation of these consolidated accounts. So there's 2 bits to this auditing of these local accounts, isn't there? There's the internal auditing by the organisations themselves, and then there's the external local auditing. So can we just deal with the internal auditing? What can you do as in charge of finance to make sure that the local bodies actually prepare their own accounts on time, ready to be audited?
So, I mean, there's a lot of work in hand on this, and Mr. Kelly may wish to jump in as well. I mean, essentially, the year we're referring to here was a complicated year because there were more audits required to be done because of the setting up of ICBs. So there are more audits to be done. And there were particular issues in the local audit market with a small number of firms, one in particular. Which
Hang on to that. I just want the internals first.
Yeah. So what can I do about it? We're doing a number of things, working with the NHS. We are engaging the market to try and build capacity in the local audit market.
It's the internal audits. It's not the external local auditors. It's your own internal systems preparing those accounts, ready to be audited.
I mean, I'll answer for the department, and then Mr. Kelly can answer what he's doing internally for the NHS. So, from the department's perspective, we have actually brought the department's core audit forward by 2 months for the year we're talking about here, which relates to us working through primarily the COVID issues that we've spoken about earlier. So, we're in a much better place now to do the department's core audit. The issue has emerged in the NHS's local audits, as you say. I mean, Mr. Kelly.
So in terms of the ability of providers and integrated care boards to actually do the preparation of the accounts, clearly as we came through COVID, that was a bit of a shock. We saw last year that the number of providers who were late in completing their accounts was reducing. The position for integrated care boards was more complicated for the reason Mr. Brittain said, in which we were both closing 100 and odd clinical commissioning groups, setting up integrated care boards. So that was, I think a genuine reason why that was more complicated. Clearly, this year coming, that's not the case because the integrated care boards are set up. So I am more confident about their ability to do it on time. I'd hope to see continued progress with the individual providers. For those who've been late, we engage with them. We check early on where they are. So, you know, that's the kind of ongoing dialogue to make sure they have what they need, and if there are any particular problems or they need to source help, then we can help and support them.
Very helpful answer. Now, Mr. Brittain, coming on to the bit of the answer, or the bit of the problem, if you like, that you're longing to come on to, and that is the local audit itself. Can I ask you what steps you're taking to make sure that there are sufficient number of local auditors, sufficient people in the firms to be able to do them? Your annual report and accounts refers to one particular auditing firm that's been a problem. I'm not going to name them because of the reasons that Sir Chris has set out in his written letter to us, but there clearly are problems with this whole auditing programme. What are you doing to overcome those problems?
I think the first point I would mention is that the department doesn't have all the levers within under its control to on the local audit. You know, the issues in the local authorities are particularly well known and have been discussed previously by the committee. I think what we are doing, though, is doing all we can to make sure local audit issues, as they refer to the department in the NHS, are managed and mitigated. So a number of actions. We're trying to build capacity in the local audit market. The NHS has engaged with potential new entrant firms to join, and I think a couple are joining as a result of that. We're performance managing them much better as well, I think, and trust to performance managing audit firms much better as well, in the sense that clearer deadlines are being set, they're being held to account for delivery and slippage much more effectively. Audit firms which haven't performed in previous years will be getting fewer audits in the future. We're also engaging across Whitehall and with the Financial Reporting Council to look at things like, with the NAO, what's the largest number of audits? If they were late, we could rely on alternate procedures to allow the NAO's audit to go ahead. We're working with the Financial Reporting Council to look at things such as reducing, or particularly the threshold at which audits have to be done at, the particular bits of the audit which take the most time. So we're looking at, can we finesse the audit requirements to make them less onerous so they can be done more quickly.
Can you give us an example?
So, I mean, there's a major local audit threshold which is being considered by the FRC, I believe, which is which, if it was at a certain level, would mean less ICBs would be covered by it. So that drives audit requirements. So that's a particular example. At the department level, we're also working with the NHS and with trusts to really set expectations around the issues that have arisen that trusts are responsible for, making sure audits are done on time, and as I said, performance managing them much more effectively this year.
So I thought, Mr. Brittain, you were slightly skating over the problem when you said that you didn't have the levers under your control.
Not all of them for the whole local audit market.
No, I accept not all of them, but a significant number you do have. There's 130 odd trusts now going down to 42 ICBs. It is incredibly important to the department that these accounts are audited on time, because otherwise they're not consolidated into your main accounts, and then they get they get qualified. So what are you doing now, 10 months ahead of the year end, to make sure that there are sufficient auditors who are prepared to do this work, with sufficient number of qualified people? It's the same problem as in local government. What are you actually doing about that to assure yourselves that once the accounts are prepared by the internal audit teams, your own internal health audit teams, they go to the local auditors to be audited, that they are sent on time and they are audited on time?
So I can see Mr. Kelly comes in, but just, the points I would make first are, but when I say I don't have the levers, I mean, we can do things to incentivize firms to join the market, but we can't make them. The barriers for them wanting to enter are around fees, which we're looking at. They're around complexity and risk. So, as I've mentioned, some other things we're doing around that. So I think we're doing what we can to incentivize and encourage firms to join the local audit market. The particular issues we've had are around the number, capacity and capability of the ones this year, though. But Mr. Kelly,
I mean, we go into completing 23-24 with every single NHS provider and integrated care board has an auditor appointed for next year. Now, actually, last year that wasn't where we were. My team worked very hard with some of the national firms to make sure they could pick up organisations that didn't have auditors, but in some cases those started later. Whereas this year we start with, today, every NHS organisation has an appointed auditor. That just puts us in a much better position, and the audit firm with which we have had significant problems, they were auditing about 20 organisations, they're now auditing 6. So we think they're kind of, where we've been most concerned, we have reduced our risk, and we will continue to performance manage the position.
So I still haven't got the answer to my specific question. It's one thing having an auditor in place. It's another thing making sure that they have the people to be able to audit them in time as soon as they are given those.
And our experience of last year, 22-23, with one notable exception, the issue was not significantly audit capacity. I think we do find, particularly as you sort of hit the summer period, that there are some trade-offs that are being made in firms between the kind of local authority and NHS market, which is why I think it's going to be hard for us to rapidly move to having completed all audits before the summer recess. But the reason why we slipped across the calendar year was due to one firm. I mean, basically, the vast majority of audits were completed by September. We go into this year in a much better position.
Well, I'm glad to have that very clear answer.
Can I just chip in before Sir Geoffrey continues? Because when we had the Treasury and we had, obviously, Kat Little was then, well, she still is, of course, second mistake, but dealing with some of these issues, there was a drive across government to try and encourage people to go into public audit. Yes. Mr. Kelly and Sir Chris, or Andy Brittain, are you part of that drive to encourage people into the exciting world of public, which we might all think is exciting anyway, but how we share that enthusiasm for why it's important and why people going in for qualification should consider this line of work? Because at the end of the day, what you're doing is quite interesting, but it might not feel like that if you're in a firm and you've got private options to go for.
I can't say that we are part of some national campaign to get people to go into the public audit side of the accountancy firms, although we're happy to participate in whatever exercise is done. I mean, but the thing we are really doing, and Andy referred to it, is to work with other audit providers to see if we can basically increase market capacity. And we have 3 examples of foundation trusts who have taken on auditors who previously weren't engaged in this market.
Chair, sorry, just to add, I think that the FRC, I think, is working on a local audit workforce strategy as well, and the department is on the steering board for that. And we're
So you're putting your foot in that door. It's just
absolutely
because it's a way of enticing people in. If we can see the actual reality of what it means on the ground.
It is to Sir Geoffrey's strategic point about overall capacity within the system. I think that's that piece of work is definitely something that we want
have
to
rehearsed that endlessly with your sister department. So, thank you, Sir Geoffrey.
So, Mr. Brittain, you referred to fees. The Department of Levelling Up have been on this for at least a year, probably longer, and they have recognised that fees need to rise in this local government auditing sector. Yep. They have the individual local authorities have now increased their fees considerably, as I know from the complaints from my own council. But that does encourage more firms to come in, enable them to pay their people properly, and to train up new people. Now, I don't think the NHS has entered that sort of increased fees to the same level as the local government sector. So what more can you do?
Well, I don't know about the direct comparator with the with local authorities, but I do know that
work for similar pay.
Yes, so I do know that since over the last since 2019, fees for local audits that NHS trusts have paid have broadly doubled. I can provide you some detail on that. If that would be helpful.
Double, actually.
Yeah. But I think, I've spoken to one of the big 4 audit firms myself, and it isn't just fees. In fact, that's not one of the primary considerations for them. It is around specialist staff to do local or public sector audits and the level of risk and complexity that they bear.
Yeah, I think.
Well, it does to an extent,
if you're
but
paying the right fees.
Yes.
They're able to pay their people properly, which will encourage more people to want to go into the public.
It does to an extent. So maybe the fees have to increase further.
I might be wrong. I expect the CNAG knows better, but I think we've always had a very different system from local government. I don't think we've ever set national rates.
No, I'm not suggesting that.
No. So,
actually, I think NHS
i.e., it's been more fluid to the state of the market than the system in local government, where I think it's set nationally. Is that right?
Yes.
Mr Davis.
To come in, I think the situation is, audit is purchased in bulk through large framework contracts for local government, so that's where there's a different approach to fees. And also the fees dropped in the local government sector in a way they didn't in the NHS. It became intensely competitive for a while, and they dropped to an unsustainably low level, which has had to be corrected. So I don't think the NHS has had to do that, but it has faced quite steep increases. And in fact, there have been I know that there's some NHS trusts who have found it difficult to get any bids from any firm to do their audit at whatever the fee, actually. And so I think this is I think it's right to focus on capacity as the key issue and the risk appetite of the firms to engage in work which had, I think, historically been seen as low risk and predictable, but became, certainly in a regulatory sense, higher risk for them. And that's certainly one of the key issues at the heart of the local government problem. And in essence, I think that the pressure on NHS audit capacity has been the backwash from the big issues in local government audit, because it's in many cases the same teams in the firms that do both types of work.
As I say, we've rehearsed this quite a lot with our assistant committee, but we've been worried about the bleed across, as Sir Geoffrey's highlighted. Sir Geoffrey, just come in.
So I think really, Sir Chris, I want to just end this on a note that this is a serious problem. Can I have an assurance that you're working within the auditing sector, both with the FRA, SA, with the individual firms, to make sure that there is sufficient capacity? And I wouldn't dare disagree with the CNAG. It's all about capacity.
So we recognise this as a serious issue. As I think you've probably gathered by now, most of the frontline work about actually getting this audit into this trust is done by Mr Kelly and his colleagues at NHS England, and then what we do is what's the supporting national stuff we can do over the top of this. But this requires considerable effort by NHS England, doesn't it, to get to the better position that you've described?
Yeah, and I mean, as the CNAG said, we've had organisations with no audit firms interested, and then we have worked with the audit firms to persuade them this is worth doing. And as I said, we start this year with every organisation has an appointed auditor, and we've managed to minimise the risk on the one firm we would have been really significantly concerned about.
Thank you, Chair.
Thank you very much, Sir Geoffrey. Jonathan Jorgley.
Thank you, Chair. I think what I'm going to say may cross a bit with Sir Geoffrey's comments, but the timeliness of filing accounts is, of course, a very important issue. And group accounts, I believe, have been laid late in January for the fourth year in a row now. So I think this deserves looking at in a bit more detail. And I'm going to start off with the Consolidated NHS Provider Accounts Annual Governance Statement. Mr Kelly, do you have a copy of that to hand? I
actually don't have a copy of that to hand.
Okay, well, I'll read it out. So NHS England continues to work to improve timeliness in financial reporting, including, and there are 6 important proposals here, which look very good, and basically I want to see to what extent you're acting on what you said you would act on. So the first one is encouraging auditors to give clear reporting to audit committees where the preparer's quality of draft accounts or working papers needs to improve. Is that happening?
Yes, and we have a regular stock take with all of the audit firms to make sure we are receiving the feedback that they are also giving to the organisations, and my teams review actually the I forget the acronym. Anyway, the letters, the reports that the external auditors give to each organisation.
Thank you. Working closely with providers to ensure they appoint external auditors in good time, which helps increase the likelihood of deadlines being achieved. So have we covered that one?
Yeah, I think that's where I said we go into this year with every organisation with an appointed auditor.
Yeah. Regular engagement with partners, including the Department for Levelling Up, Housing and Communities and the Financial Reporting Council, on policy matters affecting the broader local audit system. We believe strongly that firms having sufficient capacity across their wider portfolio of work to enable effective interim audits at NHS bodies is important for success.
I think we just covered that. That is where we work with the department and the cross-government group.
Agree. Working with providers where financial reporting issues arise to ensure they are able to address findings effectively.
Yes, and I would say, I mean, we have had one provider where we had a major issue, University Hospital Leicester, who have now close to finally resolving those issues. We've worked very closely with them, giving them specific support.
Regular engagement with the audit firms and responding to their feedback to continue to strengthen the NHS financial reporting landscape, and working with partners to make sure training and guidance is available for preparers. And
I think I just discussed we meet regularly with all the audit firms. And actually maybe one of the advantages we have had is that as a single team, we do act as a single point of both advice to NHS organisations as how to interpret the guidance, how to help the audit firms with NHS organisations. I think that is actually an advantage.
And you have adequate capacity to do that across the course, do you?
Yeah, I mean, we have just gone through a major reorganisation, and I've got a team who are been under a lot of pressure, but you know, we are building. So we are kind of even right now about to start re-recruiting to that team.
Finally, liaising with broader stakeholders on wider matters that can cause delays in NHS accounts. For example, sign-offs of local government pension scheme audits, which directly affects a handful of NHS providers with a corresponding impact on these consolidated accounts.
So that is clearly less within our control because it depends on the kind of local authority. Again, we work with them to see we can do everything we can. There are one or two examples which I think are going to remain a problem, and then we work with the National Audit Team to make sure we can effectively put in place other means and sort of reassurance processes so that we can materially reassure our consolidated accounts.
And are there problem issues that are going to lead delays that you see now or that you need to highlight if it's outside of your control?
I don't think there are things now that I'm saying that I think that I'm hoping will sort of lead to the level of delay we've seen this year. I think there are one or two organisations who will continue to have problems closing out the valuation of their local authority pension schemes. I don't think those will be automatically resolved, but that's where we work with our kind of external auditor to make sure we find other means to provide the reassurance that we need.
So Chris, having heard all of this tremendous work being done, are we going to have our accounts filed at the right time in the future?
Well, I mean, we did file them at the right time. We hit the statutory deadline. Obviously, we want to do better than that. I mean, there's a colossal challenge here built into the whole system that basically we're producing accounts for about 8% of the economy. That is an incredibly difficult thing to do. And I've done this for a while now, and every year there is a new challenge, difficulty, etc., that we did not predict. So I don't throw around guarantees for reasons you'll understand. I'm very confident in the work that's been put in hand, both by Mr. Kelly's team at NHSE and by Andy's team within the department. So I'm confident that we are doing all the right things. I think, Andy, we're expecting to be able to do it slightly quicker this year.
Yes.
But there are a lot of variables. Both on our side and on the National Audit Office's side. So you have our assurance that we think we are doing all the right things. We think again, I'll see if the CNAG shakes his head at me, we think working relations with the National Audit Office are absolutely excellent and that we are all on the same page.
Always wise to praise your auditor.
Well, also happens to be true.
I don't think it will.
This is why I check that I'm not having a shaking head while I'm saying this. So we think we've got all the right things in place, but with that caveat that this is a huge consolidation. I mean, nobody else has to try and consolidate. Well, other than Treasury on the whole of government accounts, no one tries to consolidate anything this complicated, and that throws up new issues every year. I think we're expecting a sort of slight advance this year. Not as much as we want.
I mean, both the UKHSA and the NHS accounts have to be substantially complete before we can lay the group accounts. As I said, as we've discussed earlier, we are working to sort of a November time scale for UKHSA's accounts, and we'll be aiming to lay our accounts then slightly earlier. I mean, our overall aspiration is to sort of bring it forward by at least a month each year. I think moving towards pre-summer recess will require a fairly sizable change in the sort of capacity of the local audit market, particularly. But we've discussed that and we're working towards that. So it's absolutely our aim to keep bringing them forwards.
Okay, thank you. Sir Geoffrey.
Chris, I know the change in discount has reduced the provision for litigation claims hugely in your accounts. Nevertheless, it still remains at a very high figure. What actions are you taking to try and reduce that whole...
this is clinical negligence.
Yes, clinical negligence.
I'll ask Andy on some of the technicals. The single most important thing, and my Secretary of State has been talking about this a lot recently, is of course to reduce the number of incidents that lead to clinical negligence claims, and that's indescribably more important than anything, not just because of the financial consequence. As I'm sure you'll remember from when we did a whole session on this, a very small number of the total number of claims, particularly in maternity, lead to a very large quantity. So getting maternity safety right, and we've made a whole series of announcements around that recently, is absolutely core to it. It's one of the areas, as I'm sure the committee knows, where we don't benchmark that well compared to a lot of systems that are similar to us. And we and our NHSE colleagues who work on this more directly, that is one of our big objectives. So that's probably the biggest thing. There's then a whole series of issues about how we actually manage the clinical negligence system, which I think Andy can probably describe better than me, about how we and NHS Resolution manage claims and deal with the results. There's a huge headwind, however, which is not a bad headwind, as it were, in that because of advances of medical science, a lot of people are living after medical accidents a lot longer. That is an unadulterated good thing, but it does push up our clinical negligence cost simply because you are paying for more years, which is completely right. Fantastic people are living longer, and absolutely right. So, and again, that puts, as I say, the real answer here has to be to reduce the number of negligent accidents in the first place. Do you want to say a bit about the actual management of the...
Yeah, I mean, the only thing to add to that is, yes, the cash cost of claims has increased over time. The provision...
I think it's actually the biggest liability on the whole of government accounts.
Yeah, so
significant.
The provision is 70 billion. It's come down from 130 because of the change of the discount rate. I mean, as Sir Chris said...
Which is just, I know we sort of have I'm not sure we all understand the discount rate. We could explain it, but perhaps you could explain in broad, simple terms what that means for anyone who's under... It's not a cut.
No. So, I mean,
just be clear. This
is an estimate of the total cost we're likely to pay out in the future.
Yeah.
That is discounted by an inflationary factor to try and get it into today's prices. As the inflationary factor changes, the sum of the future stream of costs we're expected to pay out changes too, and that's essentially what's happening.
Just to be clear, just anyone who might not follow the details of discount rates, this does not mean there's less money available.
No, absolutely not.
It's
just our estimate
as it's recorded in the accounts.
Our estimate of the future cash flow, the future cost. Yeah. So as Chris said, NHS Resolution processes these claims on our behalf. I mean, one of the changes we have made or will make in 2024 is introduce a new system of fixed recoverable legal costs in claims up to 25k, which will enable faster processing and lower legal claims costs. So we're working to improve the way things are done as well.
Okay. I mean, one of the things when we looked at this before is that often there's a lot of blame on lawyers, but actually sometimes the delays have been on the NHS end as well. Is it still the right way to do it that to have a litigious approach? I mean, you can't stop someone suing, but has any thought been given to doing it in a different way so that if like the Criminal Injuries Compensation Board has tariffs, has anything ever been considered to reduce the costs of managing the process?
Not that I'm immediately aware of. I'm sure there has, but we can come back to you on that.
It's just that we looked at this for. I mean, I've been on the committee nearly 13 years.
Yes.
We've been looking at this issue all of that time, and it's just always, well, for the reasons that Chris outlined, going to be expensive, but because it's some people will just need the care that they need.
Yes.
And yet it has to go through a litigious process to prove that, when actually sometimes it's just obviously going to be the case that someone needs that care. There will always be some cases that will go to court. I'm just asking the question. So, Sir Geoffrey, back to you.
So, Chris, your detailed answer gave me time to find the right piece of paper. I now have the figures in front of me.
Long answers have a benefit.
I'll use them more in future then.
According to NHS Resolution's annual report and accounts 22-23, 41% of the 2.6 billion paid out in clinical negligence payments in 22-23 related to maternity care, around 1.1 billion. And at an NHS England board meeting reported that 3 billion was spent on maternity and neonatal services. This would mean that spending on clinical negligence claims relating to maternity services in 22-3 was actually a third of that spent on maternity services. So you did refer to this in your earlier answer.
No, absolutely. No,
and I'm really going to ask you again what specifically relating to maternity services you can. I mean, clearly this is a very high figure. So I accept that some of the individual claims are a great deal of money, but nevertheless, each claim is a tragedy for the person involved.
Yes, no,
what more can you do to actually reduce this area?
I mean, you're absolutely right. Of course, the primary consideration is to prevent the incidents happening in the first place, and not for financial reasons, for clinical and public interest and individual safety reasons. Now, it's not unusual at all to see that profile when we look at our international comparators in the United States. You see exactly the same pattern because of the nature of the service. Now, the NHS, and I might hand over to Mr. Kelly in a moment, has an extensive programme of how you improve maternity services, and I said my Secretary of State's made some announcements on this recently. Again, when we look across the world, there is no silver bullet. It is about every maternity centre in the country doing the basics properly, being properly staffed. Patient voice in this is incredibly important, and as I'm sure you know, has not, or when we look at the areas we had to do inquiries into due to the nature of the problems, that has been a huge thing. One of the things my Secretary of State's particularly concerned about is some of the disparities in this area between particular ethnic minority groups and the white population are just not acceptable and need to be dealt with. And there's a very shared understanding across the department and the NHS and individual trusts that huge improvements need to be made. And as I say, a number of the figures, not just the ones you've read out, but on the individual cases, this is something we just have to get better at. But as I say, it's very hard yards. There isn't a beautiful policy solution or whatever. It's about lots of people doing the right thing every single day in every maternity service. But Julian, do you want to describe what the NHS is doing?
Chris has just outlined the kind of 4 key themes. We've published a 3-year maternity improvement plan. More staff. I mean, even in the last year, we've had 1,000 more midwives, over 100 more obstetricians. We've invested £180 million to support trusts so they can put those staff in place. As we just said, actually listening to women, I forget the precise acronym, I think it's the Maternity Voices Services Programme. where we've just announced actually coming out of the budget that we are increasing investment into that to the tune of £3 million a year, improving culture. Now, where we identified the trust with the biggest issues, you have a maternity service improvement programme. We're currently working with 33 trusts on how they can just get the right processes in place, get the right leadership, get the right culture, and then it's the data. And Bill Kirkup's report coming out of East Kent said we've got to do improvements there, so we have a whole programme of work, to use his phrase, so you can pick the signals out of the noise and spot the problems early. And I think it's worth saying, in the run-up to the pandemic, we were making quite a lot of progress. Big improvements in neonatal mortality, the stillbirth rate, that has stalled as we've gone through COVID, but I think the last data does, again, showed some improvement. So a lot further to go, a lot more work. It's a challenging area, but those are the things we are doing.
So, Mr. Kelly, those improvements, you're working with trusts, and you're working with my own trust after it's some particularly difficult problems, one or two, and that's appreciated, and I think they are putting in some useful improvements, so that answer is hugely appreciated. I suppose, Sir Chris, at the end of the day, this is all about people who suffer these problems. So simple answer, in terms of the NHS as a whole, is the number of litigation claims going up or down?
I'll check the exact numbers for you and let you know.
Zoe.
Yes, I have some follow-up questions on the maternity negligence claims and what you're doing to actually lower those claims, particularly around workforce. We've often heard a lot about continuity of care being essential through maternity. Where are you with that and the plans for that?
So the plans are still ongoing. I think the key thing with continuity of care is though making sure you've got sufficient workforce to resource it properly. So arrangements have been put in place that just to calibrate the rollout in individual trusts depending on just having sufficient workforce to do it. But as I said, we have significantly increased the number of permanent midwives. We've materially increased the number of obstetricians. We have a programme in place to continue to improve that over the next couple of years.
So in terms of continuity of care, with those improvements to the workforce, are you seeing improvements in continuity of care, or are you going to have to move to prioritising areas and patients that are particularly vulnerable? For example, black women who are still 4 to 5 times more likely to die during childbirth.
As I said, I don't have the precise figures on the rollout of continuity of care at my fingertips here, so we can come back on that, exactly where that is. But as I said, we've had, it's calibrating it so that in each individual organisation and unit, you've got sufficient staff in order to roll it out.
Now, you're saying you don't have sufficient staff?
I think in some places we haven't always had sufficient staff to go at the pace we would want, which is why we are increasing the number of midwives and have gone a long way to increase it over the course of the last 2 years.
Certainly in my own hospital we've seen a challenge where a number of midwives left after Brexit, so that was a challenge. There's also been some interesting work done to support black women in pregnancy to make sure that they are supported and feel more confident about what's being offered, but also have a chance to ask questions to try and make sure that there are some of the issues that are causing the higher incidence for black women is being addressed.
The only thing I was going to add, we're very lucky in the department that our Chief Scientific Advisor, Professor Lucy Chappell, this is her area of professional expertise. She's seconded to us and she still works in the area as well as being our CSA. The two big points that she makes is, one is focus on a small number of simple things, exactly at the type of as Owen has been describing, and secondly, that the underlying health of people before they become pregnant is vitally important too. So the sort of health disparities end, who smokes, who drinks, all the all the
public health,
all the classic things is one of the things that determines successful outcomes. So it's not all about the maternity unit, it's also about the health outreach that I was going to describing of the sort of whole thing. So as I say, there's no silver bullet, but I say
maybe
it's
that
huge.
it's time for the Public Accounts Committee at some point, maybe our successor committee, given where we don't know what's going to happen next week and weeks to come, but to look at the whole issue of
I mean,
because it's many layered.
Exactly,
but
and
it's what we don't want to talk about people's lives in just in cost terms, but it is also cost effective for the taxpayer to give people healthier outcomes.
No, I mean, this is what I was going to say. We have, as I say, we have some very serious experts in the department, and if the committee wants to get into that issue,
we will
want a
decide
rather different
I think
panel.
just given the hour, I just wanted to touch on one important issue about the incidents incurred but not reported, where you rely on, or the NHS relies on the Government Actuaries Department to assess the potential value of those. So they are accounting estimates, but they're determined on the basis of information currently available on similar incidents. So it's a proxy for what you might have to pay out. Do you have any idea, Mr. Kelly, how accurate the actuaries' work is, and whether that causes any other potential challenges for you if you're they're pretty good at what they do, but they can only go so far. Do you get any surprises as a result?
So I'll say that I'm actually not aware of that work. So I'm really happy to sort of take it away and go and look at it.
Because part of it is obviously, as Owen's highlighted, it's preventative work, and as Sir Geoffrey said, we highlighted the big stuff, but we do need to know that there's some approach going on to managing this and understanding the potential to see this increase for all the reasons that we know, but trying managing it. Very interesting area. We could go on forever on this and many other issues of the accounts, but I think in this very warm room this afternoon, the witnesses will be pleased to know that we have come to the end of our deliberations today. So can I thank you very much indeed for our time. That's Julian Kelly from NHS England, Professor Dame Jenny Harries, Chief Executive of UXA, UK Health Security Agency, Andy Brittain from the Department of Health and Social Care, Sir Chris Wormald, Permanent Secretary at the Department of Health and Social Care, and Shona Dunn, Second Permanent Secretary at the Department for Health and Social Care. We'll be producing a report on this after the Easter recess, assuming there is no election called next week. If there is an election called next week, then you get away scot-free, because unless we can turn a report around in 24 hours or a week, because it's unlikely that we'll be able to do. We might try something in that case, but so there you go. There's a group of people now wishing for a general election sooner rather than later, despite their impartiality. Can I thank you very much indeed for your time? The transcript will be available on the website uncorrected in the next couple of days, and many thanks to our colleagues at Hansard for their work. Thank you very much indeed. Order.
Thank you very much.
The proceeding has ended. 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 The proceeding has ended.